All right, hello everyone. So we have gathered today to discuss the questions of orthodontics which had come up in the recently concluded exam for medical officer in Rajasthan. So I think the paper was conducted in the month of July only, early part of July. So here we are to discuss the questions which were asked about the subject on orthodontics. There were total 7 questions which were asked. So let's start with the first question. Question asks that rhinometry test can be used for the diagnosis of which of the following oral habits? So rhinometry test. There should not be any confusion in answering this question. Rhinometry test is used for the diagnosis of mouth breathing habit. Now, if you look at the definition, it should be rhinomanometry, not rhinometry. Rhinomanometry measures air pressure and the rate of airflow during breathing. These measurements are then used to calculate the nasal airway resistance. There's one more technique, an advanced form of rhinomanometry that is called acoustic rhinometry, which uses reflected sound signals to measure the cross-sectional area and volume of the nasal passage. It is a non-invasive examination that measures the cross-sectional area of the nose using reflected sound, just like an ultrasound, no? As a function of the distance from the nostril. So the correct answer for the first question, that is rhinometry test, can be used for the diagnosis of which of the following oral habits? That is mouth breathing habit. That is called mouth breathing habit. Next question. The serial extraction procedure is used in orthodontics during corrective orthodontics, preventive orthodontics, interceptive orthodontics, or surgical orthodontics. Well, serial extraction, we know it is not a surgical one. It is not a corrective one. So the confusion lies between preventive and interceptive orthodontics. Now, the correct answer for this question should be interceptive orthodontics. Why? Because you have intercepted something. We have intercepted something. We have intercepted something. We are doing some procedure. We are intervening basically. We are intervening by means of extraction of the teeth according to Tweed's, Duell's, and Nance method. Right? That is why it can be considered as an interceptive technique. Just a brief introduction about serial extraction. What's the rationale? It allows for growth of the jaws, dentitional adjustment in the anti-segment during first and second transition period. Then dental crowding is a result of inadequate arch size. Serial extraction aims to correct this discrepancy by reducing the tooth material. We are basically reducing the tooth material by extracting the teeth in a serial way. First, the deciduous canine is removed, followed by removal of deciduous first molar, followed by removal of not yet erupted permanent first premolar. Right? So we are reducing the tooth material. This physiological tooth movement or drifting occurs at the time and site of extraction. So that is the rationale of serial extraction. What are the benefits? It guides or encourages eruption of permanent teeth in a favorable position. It reduces malposition of the individual teeth, avoids loss of the labial alveolar bone, and reduces treatment time when active orthodontic treatment is required. So basically, we are intervening. We are intervening something. That's why it is classified as an interceptive orthodontic procedure. Now, this is what is Duell's technique. We go for extraction of deciduous canine, followed by extraction of deciduous first molar, followed by extraction of first premolar. Similarly, we have Nance and Tweed's technique, where there is first extraction of deciduous first molar, followed by extraction of first premolar, followed by extraction of deciduous canines. So there's a sequence, that is CD4 for Duell's technique and D4C for Nance and Tweed's technique. Okay, so that is what serial extraction is. Next question. The appropriate common age as recommended by orthodontic clinicians to visit for abnormal individual for the orthodontic problem is. Now the question is asking, actually the language of the question is not that it is not that well intercepted by common man. What I reckon from the language of the question is that what is the first time the parents should take their child to the orthodontist if they see any abnormality developing in the child's mouth, any crowding developing in the child's mouth. I think that is what the question is asking. Now, according to certain authors, according to certain journals, this is the reference which I've got. According to the SRM Journal of Research in Dental Sciences, the American Association of Orthodontists recommend that every child have an orthodontic examination by the age of 7, first time. However, a general rule of thumb is your kids should look at getting braces between the ages of 9 to 14 years of age. Usually, this is before they have gone through puberty. If they have already gone through puberty, it means it will be harder to adjust their jaw or teeth as they have already settled into their post-puberty positions. Now, pretty simple to understand this this box here, this paragraph here. American Association of Orthodontists recommend that every child should visit an orthodontist for a normal routine examination, for a normal routine consultation by the time the child reaches the age of 7. That is when you have the permanent centrals and laterals erupted. Even the permanent molars have also erupted by the age of 7. So in the early mixed dentition stage, it is recommended by the American Association of Orthodontists that is the right time for the child to visit an orthodontist for a quick checkup for the first time in his life. But as a rule of thumb, the children should look at getting braces between the age of 9 to 14 years of age. That means during the late mixed dentition stage, or after 14 years, that is after the full complement of permanent teeth have erupted. That is again a subjective decision to make. That is entirely at the discretion of the clinician, of the orthodontist himself. Okay. So the correct answer will be 7 years of age. Okay. To provide three-dimensional control in fixed orthodontic treatment, the balanced use of following components are required: 2 force systems, force and a couple, 2 couple system, and force and a moment. Now this is quite an obvious choice. What should be the correct answer? The question is asking to provide for a three-dimensional control in fixed orthodontic treatment. Means we have to have the utmost control. We should regulate the mechanics of the teeth in such a way that the orthodontist is able to control the movement of the teeth in all 3 planes of space, in all 3 dimensions of space. That means the orthodontist should have full control to the movement of the teeth, and that is possible only and only when we incorporate a 2 couple system. When we incorporate a 2 couple system into the fixed orthodontic brackets. Now, what is a 2 couple system? It's a statically indeterminate system where it is not possible for the operator to individually measure the forces and the moments which are generated on the each bracket slot, each bracket and wire slot individually. That is what statically indeterminate system is now. So we have 2-point contact, we have good rotational control, we have got good vertical control, we have got both anteroposterior control, only and only if the wire, the arch wire, is fully engaged into the bracket slot to provide a 2-point contact, leading to generation of a 2 couple system. Okay. Next question: the common material used in fabrication of the arch wire, that is an active component of the fixed appliance therapy, to provide light optimum forces. That means the question is asking whenever the patient has crowding in the teeth. So the first wire which should be used should be flexible. We have discussed about that earlier as well. So the objective is to provide light, continuous, optimum forces. Why light forces? Because the light forces are easily tolerated by the tissues of the body without inducing any noxious stimuli in the form of pain. And light forces are required only when, rather not only when, they are required when we want to have frontal resorption of the bone to cause orthodontic movement of the teeth. That is what is desired, no? Light orthodontic forces, light orthodontic continuous forces whenever we talk about fixed orthodontic appliances. So the first wire which should be used to unravel the crowding should be flexible enough, should have a large range of action, should be springy, and should be able to retain the shape memory. So all these characteristics are defined by nickel titanium. They are defined by nickel titanium. Now, as the patient, as the stage of the treatment advances, from initial labeling alignment to space closure, finally to finishing and detailing, we have to change the wire sequence in accordance. That's what the principles of fixed orthodontic treatment is, no? So first sequence of treatment is labeling and alignment and labeling. So we want to level the curve of P. We want to make the teeth come into proper alignment, no matter whether they are tipped or talked or crowded, lingually placed, buccally placed, highly placed, whatever. We have to bring the teeth into alignment. That is the first objective in the sequence of the treatment. So that labeling and alignment, that unraveling of the crowding is brought about by nickel titanium wire. Now the next stage is space closure. Now after nickel titanium, the next wire which is most commonly used is a round stainless steel wire, then followed by rectangular nickel titanium wire. This is round night tie. First is round night tie, which should be flexible enough. After rectangular night tie wire, we have a rectangular TMA wire, and after that, a final stage of the treatment should be rectangular stainless steel wire. So you can notice here that the modulus of elasticity of these materials, they are increasing. The night tie has got the least modulus of elasticity, followed by the TMA wire, followed by the stainless steel wire. So the modulus of elasticity increases from round night tie to rectangular stainless steel. So this process, when we put the arch wire, different types of arch wire having different cross section, different diameters, different dimensions, so that process is known as variable modulus orthodontics by Burstone. His full name was Charles Burstone. This is called variable modulus orthodontics. Now, a peculiar characteristic about nickel titanium is something called twinning. Now, what is twinning? It's a phase transformation which occurs at the molecular level. So the nickel titanium is available in two forms: austenitic night tie and martensitic night tie. So austenitic night tie is the one which is present just like that. I mean, there is no external forces acting on it. So whenever any external forces acts on the austenitic night tie, so this is the direction of external force, the direction of arrow. You can observe that the top layer of the molecules, they are changing their orientation in a way that it changes its form. The top layer of the molecules change the form. They also change the shape of the shape of the wire as well. But at the same time, you can notice that the relative position of the atoms or the molecules in relation to each other is not changing. The relative position of the molecules in relation to each other is not changing. So this process is known as twinning. Now there is austenitic form converted to martensitic form. Austenitic converts to martensitic under the influence of force, and martensite gets converted back to austenite under the influence of heat. You can see here, if the deformed austenite is acted upon by heat, it gets converted back to austenite. Okay, this is exactly what is depicted here. There's a reversible transformation between austenite and martensitic night tie. And one more property very unique to nickel titanium is shape memory process. As I said earlier, this is the austenite, which is a normally existing crystalline form of nickel titanium. Upon cooling, or upon application of external forces. It gets converted like the phase, it gets transformed into a new phase called as twinned martensite. So that undergoes deformation under the influence of external forces to form the deformed martensite. Now, once deformed martensite is acted upon by heat, it gets converted back into the original austenite. This is known as shape memory effect, shape memory process, which is unique to nickel titanium. Lingual space maintainer is a unilateral non-functional plans, bilateral functional plans, unilateral functional plans, or bilateral non-functional plans. What do you think should be the answer? The correct answer will be it's a bilateral non-functional plans. Now, why is it used? The lingual first of all is a fixed plans. It's a non-functional type because it is not aiding in the mastication process. It is mostly used in the mandibular dentition. Why? Whenever there is premature loss of the mandibular posteriors, to maintain the space to allow for eruption of the posteriors in an uneventful manner, this appliance is mostly used, right? So this is a non-functional type passive fixed space maintainer. Where there is bilateral loss of decidus molar, a fixed lingual arch is often most satisfactory. Multiple loss of primary teeth in the mandibular arch, preferably in the mandibular arch. It can also be used in the maxillary arch. Made up of 0.036 inch or 0.040 nichrome or stainless steel lingual arch wire. We have got two types of modification in that. So we can just put a small U loop here. Just by activation of the U loop, since the anterior part of the fixed appliance of the lingual arch it rests against the cingulum of the lower anteriors. So just by small activation of it can lead to small proclination of the lower anteriors, resulting in improvement or resulting in elevation of the crowding. That is number one modification. Number two is called Mershon's modification. So what is done here? A small spur, a small U shape is given in the arch wire, which is placed just distal to the canine. So what it does, it doesn't allow for the posterior movement of the anterior segment. That means it doesn't allow for the collapse of the lower anterior segment. So that is what Mershon's modification is. Next question. I think this is the last question. The most common, removable, patient-friendly myofunctional plan used to correct the class 2 different malocclusion in a growing individual is. Now, myofunctional appliances are mostly given in growing individuals who have entered the pubertal growth stage or who are in the circumpubertal growth stage. Options are bionator, twin block, activator, Frankel. Now, by the very basic design of these appliances, activator is a loose fitting appliance. Number one, it is quite rigid actually. It encages the tongue completely. So there is no degree of freedom. The speech is affected so much so that the patient is not able to wear the appliance at all. So it is not very well accepted. It is not very well tolerated by the patient. So activator is not the right answer. Frankel appliance, again, it's not the right answer because it's a very bulky appliance and it is actually very difficult for the patient to wear the appliance full time. So we are heavily dependent on the compliance from the patient side. That's why Frankel appliance is also not very well tolerated. Bionator is, it is a better appliance than both of these. It is less bulky appliance and it can be well tolerated as well. But if you compare Bionator with twin block, clinical experience says and even data also says that it's a twin block which is universally more patient friendly and more clinically accepted as compared to the rest of the myofunctional appliances as just I have described above. It is easy to wear, easy to tolerate. It does not cause any loss of degree of freedom of the mandible. The speech is not affected. Of course it is affected in the beginning. Anything new put in the mouth is going to distort the speech, but it all depends how will you manage your patient, how will you counsel the patient. If the patient is able to handle the twin block correctly, evidence says that twin block is one of the most patient friendly and most compliant appliance a patient can wear for correction of class 2 division 1 malocclusion. So this is the answer key of all the questions we have discussed in this session. That's all for now. If you have got any doubts, you are very much welcome to reach out to me anytime you want, and all your answers will be taken care of. All your queries will be taken care of.